All right, let's get right into it. Welcome to this rapid-fire, high-yield explainer. Look, if you're gearing up to completely crush your medical board exams, or maybe you just need a really rigorous, clinically focused review of infectious diseases, well, you are in exactly the right place. Today, we're taking a deep dive into the clinical mastery of Neisseria gonorrhea and disseminated gonococcal infections. I'm going to walk you through exactly what you need to know to recognize those sneaky presentations, avoid the classic traps, and, just lock down those easy points on test day. Okay, let's dive into this ward-to-board roadmap. We're hitting the microbiology of Neisseria gonorrhea, key local clinical syndromes, disseminated gonococcal infection, or DGI, ophthalmia neonatorum, diagnostic exam traps, and finally, treatments and antimicrobial resistance. Let's get moving. Starting off with Section 1, Microbiology of Neisseria gonorrhea, the pathogen profile. Because, hey, before we can treat the patient, we really need to understand exactly what we're up against in the lab. All right, this right here is a classic high-yield exam differentiator. Test writers absolutely love to see if you know your bacterial sweet tooths. You're almost guaranteed to get a question asking you to distinguish between Neisseria species based on their sugar fermentation. So remember this mnemonic. G for gonorrhea, G for glucose only. It literally doesn't touch maltose. Its cousin, on the other hand, and meningitis, uses both glucose and maltose. Catching how this pathogen processes, or actually, scratch that, doesn't process maltose, is an absolute layup for easy board points. Don't miss it. Diving a little deeper into its profile, we're tracking a gram-negative, non-motile Diplococcus. It's oxidase positive and exclusively a human pathogen. Now, if you want to culture it, you're going to need Thier-Martin medium. That's a selective chocolate agar base, and it absolutely needs a 5 to 10% CO2 environment to really thrive. But here's where the micro directly dictates your patient's fate. Think of the poor B strains like two very different siblings. The poor B1B strain, it prefers to stay close to home, causing local genital infections. But poor B1A, that one's the dangerous wanderer. It's serum resistant, which makes patients highly prone to disseminated gonococcal infection, or DGI. And that perfectly transitions us right into Section 2, Key Local Clinical Syndromes. Let's take what we just saw in the lab and walk it right onto the clinical wards. So this brilliantly illustrates the stark contrast in how this pathogen presents between the sexes. For male urethritis, the presentation is loud and clear, right? Profuse, purulent discharge, severe dysuria, and they are highly symptomatic within just 2 to 7 days. Because of this, guys usually seek treatment pretty fast. But for female cervicitis, roughly 50% of cases are completely asymptomatic. This is a genuinely crucial concept for the boards. The female population serves as a massive asymptomatic reservoir, which unfortunately opens the door to severe silent complications like pelvic inflammatory disease. And we all know that can lead to ectopic pregnancies or even infertility. Which brings us to Section 3, Disseminated Gonococcal Infection, or DGI. This is the systemic spread. This happens when the infection breaks out of that local environment. The absolute key risk factors you must remember for the boards are menstruation, with onset often within 7 days in about half of affected women, and terminal complement deficiency, specifically C5 through C9, meaning the patient literally can't form the membrane attack complex. Let's actually trace the path of DGI through its two distinct clinical stages. Step 1 is the bacteremic stage. The patient comes in with a fever, polyarthralgia, usually in the knees, wrists, or ankles, tenosynovitis, and those classic pustular skin lesions out on the extremities. At this stage, blood cultures are going to be positive. But then, boom, we hit Step 2, the joint localized stage. The pathogen suddenly settles down into 1 or 2 joints, causing a massive suppurative arthritis. And listen, here's the ultimate exam trap. By the time the patient is in this joint localized stage, their blood cultures will often dynamically shift and turn negative. If a vignette describes a hot, swollen knee but negative blood cultures, do not rule out gonorrhea. And why is that so incredibly important? Because GGI is the #1 most common cause of septic arthritis in sexually active young adults. Period. If you have a 22-year-old patient walking in with a sudden, severely swollen knee, this pathogen needs to be at the absolute top of your differential diagnosis. Moving on to Section 4, Ophthalmia neonatorum, the neonatal threat. Here we're exploring what happens when infants are exposed to infected maternal cervical secretions right during childbirth. Let's move to the timeline and see how this builds, because visualizing this is the absolute key to solving pediatric clinical vignettes. Day 0, birth and exposure. If the neonate develops tense eyelid edema, chemosis, and a profuse, purulent discharge between days 2 and 5, you're looking at gonococcal ophthalmia. But if the onset happens a bit later, say between 5 and 14 days, you really should be thinking chlamydial conjunctivitis. Memorize these specific windows, guys. They are exactly how test writers differentiate the two infections in a question stem. Now, when it comes to managing this neonatal threat, we follow some pretty strict rules. Standard prophylaxis at birth is 0.5% erythromycin ophthalmic ointment. But here's the critical distinction you gotta make. This prophylaxis prevents the infection, sure, but it does not treat it once it's established. If an infant actually develops ophthalmia neonatorum, topical treatments are absolutely useless. The treatment strictly requires systemic IV ceftriaxone alongside gentle saline irrigation of the eye. All right, lean in and listen closely for this one. We're moving into Section 5, Diagnostic Exam Traps. This is where the test writers actively try to trick you, so let's make sure you don't fall for it. Consider this a massive warning sign. A Gram stain showing gram-negative intracellular diplococci is incredibly diagnostic for asymptomatic males' urethral discharge. We know that. But if a board question asks you to diagnose a female patient using a cervical gram stain, or maybe a patient with a pharyngeal infection, that gram stain is virtually useless. It's only about 50% sensitive for the cervix, and the pharynx, well, that's already full of commensal Neisseria species that will just give you a false positive. Relying on a gram stain here is a guaranteed way to fail the question. So, what do we actually use instead? We use NAT, the nucleic acid amplification test. This is the definitive modern gold standard. It's literally the most sensitive diagnostic test we have available. And the beauty of NAT is that it's completely valid on non-invasive samples, like just a simple urine catch for males or vaginal and pharyngeal swabs. It completely bypasses the gram stain's limitations. The only catch? NAT cannot perform antimicrobial susceptibility testing. For that, you're still going to need a traditional culture. Let's wrap things up with Section 6, Treatments and Antimicrobial Resistance. Treatment guidelines have shifted massively over the last few years, and you have to know the current standard of care. Forget the older drugs, folks. Quinolones and azithromycin are out. So the crucial point here is that ceftriaxone is the undisputed star of the show. For an uncomplicated genital, rectal, or pharyngeal infection, it's a single 500 milligram IM dose of ceftriaxone. Pay close attention to the duration because test writers love to test on it. If it's DGI, you're stepping up to IV ceftriaxone for 7 days. Endocarditis, IV for 4 weeks. Meningitis, IV for 10 to 14 days. And remember, we no longer automatically dual treat with azithromycin. You only add a 7-day course of doxycycline if chlamydia hasn't been explicitly excluded. Now, what about follow-up? Do you need a test of cure? Well, if the patient had a genital or rectal infection treated with ceftriaxone, no, a test of cure is not required. But if they had a pharyngeal infection, a test of cure is clinically mandated at 7 to 14 days. Pharyngeal gonorrhea is notoriously much harder to eradicate, so you absolutely must confirm the pathogen is completely gone. You might be wondering, why do we rely so heavily on ceftriaxone? Well, because the CDC classifies this pathogen as an urgent antimicrobial resistance threat. It has engaged in this relentless evolutionary arms race against us, just systematically defeating our antibiotics one by one. PPNG strains, they use a beta-lactamase plasmid to literally destroy penicillin. TRNG uses plasmid-borne defenses to beat tetracycline. QRNG uses chromosomal mutations in GIR-I and PAR-C to render quinolones entirely useless. And terrifyingly, we are starting to see cephalosporin resistance via altered binding proteins and efflux pumps. Which leaves us with this pretty sobering final thought. We've watched this pathogen outsmart penicillin, tetracycline, fluoroquinolones, and azithromycin. With Neisseria gonorrhea evolving so rapidly, what exactly happens when our absolute last line of defense, ceftriaxone, completely fails? It's a genuinely terrifying prospect for the future of infectious disease, and it's a reality the medical community is actively racing against. Anyway, thank you so much for joining me on this explainer. Keep studying hard, and I will see you next time.